This conference will now be recorded.
It's Tuesday, September 10th, 2024. Welcome to the AnCan virtual support meeting for high risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators Len Sierra, John Antonucci, and Rick Davis, the founder of AnCan. The usual reminder about medical advice: if you think you're hearing any, think again. It's not on offer. Um, and the usual reminder, but this one won't be shortcut. Funding for this meeting comes in part from companies that believe in our mission. We're grateful. Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics. So I think, but I'm not sure whether we have a newcomer tonight. Bob P. So let me ask you, Rick. Did we do the
Yeah,
induction?
no, Bob Pethville was here last week.
Okay. Okay. So then we'll just go down the list. Jack, you were first here. What's up with you?
Okay. I won't be long. I just had a couple of things done I'd like to talk about. As usual, fortunately, my PSA is still undetectable, and the only problem I have is my absolute neutrophils stay down real low. But Belusic is not worried about it. He says it's par for the course with darolutamide. And it's sort of my 17th month on darolutamide, going into my 14th, 15th month on Orgovyx. I decided, or we decided, that it's time to do a scan. I've had 5 scans since 2017, since my reoccurrence. First, I had a C11 back in Mayo, and then it's the only one they had back then, nothing detectable. Then I had my first PSMA done at Sloan Kettering, and nothing was detectable. However, they saw some nodes up in my subcarinal area, although it didn't light up. Said, let's just check that out and get an FDG, see if there's something else going on here, if it could be more dangerous. And the FDG scan at the time, that was 3 years ago, showed nothing hypermetabolic or concerning. So I did an FDG scan on the 6th, a few days ago, and fortunately I was concerned only because I don't know what some people have been hunting for with this FDG that some people have been pushing me to do. But fortunately, it showed it was in my favor, and it didn't show any signs of metastasis anywhere. However, this is not PSMA, this is not aximum, this is not specific for prostate cancer. It's specific for hypermetabolic activity, metastatic disease. I'm not too sure. At least I've read something about prostate cancer having no great affinity for sugar, and the sugar was not observed. I saw my radiation oncologist today, Dr. Pollock, and he reviewed the film with me because I tried to do it on my own, and I got panicky because I really can't differentiate between where it belongs and where it doesn't belong when I read, and I'm no reader, far from it. And so he and Dr. Belusic both read it and said it was fine, no metastatic disease anywhere. And I looked at it today with my radiation oncologist, and he said he doesn't see anything anywhere. I said, can you I stupidly asked, can you distinguish between necrotic tissue and tissue that's been shrunken down by hormones? He said, yes, I could maybe, but there's nothing to distinguish because there's nothing observable. I said, whoops, yes, that makes sense. So I asked him then, were I to get a PSMA scan at this point, would there be any, being that I had metastatic disease, and I know, Rick, you brought this up many times, once you have metastatic disease, that PSMA can stick around quite a while, even though it's been perhaps deactivated or suppressed with hormone therapy and or SBRT. He said, it's very tricky because we may have hit it with the SBRT, but the PSMA, especially since you're on ADT, is upregulated, and it's gonna stick around for quite a while, And were you to get a PSMA with a PSA of 0, testosterone of 0, the PSMA could still show up. Yes, Rick, it can. However, it doesn't mean that it's indicative of metastatic disease. It could very well be inactivated, but PSMA avid. And it takes time for that stuff to get out of your system if it's necrotic, if it's been zapped by radiation. So you said there's no value at this point in even thinking about a PSMA scan. He said maybe if you do decide, as I talked about with him, taking a holiday, we talked about 18 versus 24 months. I'm inclined to go 24, although I'd like to see if the results of this ADREAM study at NIH comes out and see whether or not they think it's as valid to gamble on going with 18 months or as good as 24 months, if either one is worth doing, which I definitely want to do, though. There are some people who believe I should never do it. Some people believe I should only stay on it for the rest of my life. My oncologist believes it definitely should take a holiday and see how it goes, which I'm planning on doing. So basically, that's where I am, and I just thought I'd bring you up to date, and I welcome any feedback.
Well, Jack, this is John. I'm happy to hear your results, since we talked a little bit about the anxiety that you had last week. It's just very nice to hear.
Thanks. Yeah, I asked if this mitigated any chance of a neuroendocrine small cell kind of situation. He said, yeah. He said it's highly unlikely. It would be more inclined to be you'd show something if it was moving in that direction. I also found out if it did move in that direction because of the heterogeneous nature of that disease, it would be PSMA avid and non-avid both, but probably FDG positive. But that's, always something that made me a little anxious because somebody was promoting that a little too much, more than I could handle. One of my people.
And there was no real resistance from your doctor or your insurance company about paying for a scan when your PSA was non-detectable. I mean, I ask because I'm going to be talking to my doc in a few weeks, and he doesn't think there's any reason to. I'm a couple of years out, and my PSA is very low.
FDG scan, I mean, do you see any reason that the insurance would turn that down at this point? 3 years ago, I did an FDG scan.
I know why. Maybe because the last one had some possibly positive results that justified it. No?
Not really, no. There was lymph nodes that were observable but non-avid. So there was no signs of hypermetabolic activity in the.
Oh, I see. No. Yeah.
We'll see if they turn it down. I hope not. But I'm sure my medical oncologist will advocate for me. He's that kind of a guy.
Thomas M., your hand is up.
Yeah, Jack, you mentioned that you made a statement that, and I may have misunderstood, but you said that prostate cancer has no affinity for sugar. I may just be ignorant about this, but I thought that the cancer was charged up on the glucose and sugar and things like that.
Well, I said it's not very specific for sugar. That's why they have PSMA and Aximum as being more accurate. So that's been where I've been led to believe. Maybe somebody can educate me on that.
Well, I can make a comment about it. I have read that like any normal cell, prostate cancer cells like to use glucolysis and glucose oxidation for their energy, but they tend to shift their preference as time goes on to fatty acid oxidation. And that fatty acid oxidation has the capacity to contribute to resistance. And there's a little bit of research interest in whether blocking fatty acid oxidation and forcing the cell to rely on glucose can interfere with resistance at all. So that's what I know about that topic. I don't think that glucose really fuels prostate cancer cells, and I think for us advanced guys, it's probably even less likely.
And what about the fatty acid oxidation? What feeds that?
For some, in some way, you know how prostate cancer cells love to change their metabolism, and sometimes their genetics, and sometimes their endocrinology, in order to become treatment resistant. And my understanding is that this is one of those mechanisms to switch to burning fatty acids instead of glucose.
So would that mean that taking omega-3 fatty acids might contribute to that?
I doubt it, but there is not any conclusion about that to my knowledge at this point. I think that in a couple of years, if this line of research is pursued, there may be attempts to interfere with the cell's access to fatty acids as a way of getting around resistance, but there's no answer to that, to my knowledge, yet.
Okay, thank you very much.
Who
My
was that?
feeling,
I didn't see anybody's picture light up. Who was that just talking?
Thomas?
Oh, hi, Thomas. Okay.
Yeah.
Hey, Johnny, you're saying that you think that instead of using the glycolytic pathway to produce energy, it enters some kind of form of Krebs cycle for the fatty acids to produce.
Right. The cell will dodge away from splitting glucose molecules and dodge away from, did you just say Krebs cycle?
Well, I said Krebs cycle, but I meant into producing ATPs.
Yeah, and we'll dodge away from Krebs cycle, which is fantastically efficient in terms of getting energy out of glucose. I think, well, I can't remember my biochemistry to know the catabolic pathway for fatty acids, whether it feeds them into the Krebs cycle or not. I can't recall.
Yeah, me too. I'm trying to think about it, but can't
Yeah,
remember.
I can always look it up.
No, but it
so,
just seems like it'll
uh,
stop you. Maybe not producing lactate, not producing pyruvate, not entering the glycolytic pathway at all.
Well, pyruvic acid will be a product of glycolysis, and but I can't remember. How fatty acid gets all the way down to acetic acid and carbon dioxide. I just can't recall. Any biochemical fanatics here that can remember back to college?
right.
Oh, here, Dr. Jeff. Fatty acids are converted to acetyl-CoA, which can directly enter the Krebs cycle. Thank you, Jack. I mean, Jeff. Was that Jeff or Jack?
That was Dr. Jeff. Thank you, Dr. Jeff.
Thank you, Jeff. Fatty acids are converted to acetyl-CoA, which enters the Krebs cycle. Very good.
So, Rick, your hand has been up.
Yeah, I just wanted to endorse that in most cases, like Jack's, our experience has been, and we discussed this at some length last week, that taking some form of holiday is probably a good idea. Len's got his hand up. Maybe this is what he wants to talk about. But I know Len circulated something to Larry Fish, which I haven't had a chance to look at yet. So I'll defer to Len, and he can continue talking about holidays.
Okay, thank you, Rick. So what I sent to Larry Fish was a 2024 paper that was only 170 patients, and it was a retrospective analysis of continuous ADT versus intermittent ADT. And it was for patients who were a category that we're not sure really exists, but it was patients who progressed from primary therapy, and then they were looked at for progression to um, was hormone sensitive prostate cancer with progression to castration resistant non-metastatic prostate cancer. And that group that was on continuous ADT was progressed 3.4 times faster than the intermittent ADT people. Uh, so, take that with a grain of salt. Small study, retrospective analysis, but it's something. Now, the reason my hand was raised was because, well, two things. Insurance, I think, Dr. John, you were asking about that because you're wondering if you can get a scan with a non-detectable PSA. I think, another one of my favorite topics here, I think that insurance companies are covering that now because, once again, that ARCHES trial, as elaborated by Dr. Armstrong at Duke, 34% of guys with no detectable PSA showed radiographic progression when they were on enzalutamide. And presumably the same would hold true for the other androgen receptor blockers. And that was a higher rate of radiographic progression with low PSA than on ADT alone. So the addition of these androgen receptor blockers apparently forces a mutation that the cancer cell doesn't produce PSA anymore. So that's that. Now, the other thing, FDG, I don't disagree with Dr. John on the fatty acid cycle, but my understanding is that the prostate cancer is a much slower growing cancer than other cancers, which other cancers, they use FDG a lot because they're faster growing. And if your cancer is faster growing, it's going to be sucking up more glucose. So the FDG scan is usually not very revealing for prostate cancer because it's not growing fast enough. So that doesn't negate what Dr. John was talking about. Maybe it's just a secondary factor. And that's it for me.
Circling back to
Funny
where I
thing
think,
about that Arches reconfiguration that Len was talking about is that the original study that generated that data, when it was reanalyzed later, was done by my medical oncologist who won't give me a scan until my PSA gets to 0.2. Seems a little odd. No, I'm sorry, somebody I interrupted.
that was worth the interruption. I was I was going to circle back to where I think Tom was going, and it's my understanding that you can't really outsmart uh, what cancer wants to eat by starving it out. That cancer will always grab whatever you have. It will always grab the largest share for itself. So if you cut down on sugar, it will still grab the largest part of sugar. Anything it wants, it gets. So your attempt to starve it out is doomed. This is my understanding of dietary interventions.
Is that the definition of a bully?
Yeah, I love it. Yes. But
Except when you stand up to a bully, they back down. They back down.
Some do, some don't.
Yeah.
so you were not a bully. Dan, you asked very politely for time, and it's now you now have the time you asked for.
Oh, great. Just a brief summary. Last week, I got my blood test. So on my hormone therapy, I seem to have very few side effects, and we're dealing with those with different medications. But I'm delighted that my PSA went down from 15 to 10 to 2.2, and now it's at 0.52. So I'm elated about that. And I just finished up 25 sessions of IMRT. The tough thing is, I met with my doctor this morning, and I asked that I wanted to see the scans, the MRI and the comparison scan that they did. He said, there's nothing to see. And instead of 2 SBRT sessions, he wants to do 3. And I'm sorry I don't have the proper medical terminology. He said the new standards are a little to his disadvantage if he does the 2, which he had originally scheduled. He said it's easier for him to do the 3. So I'm going along with that, even though I'm not happy about it. And I'm getting an MRI for the liver on Saturday. So I'm progressing, but still not out of the woods. And I understand from all the stuff that you guys are saying, we're never really out of the woods. We're just watching whatever process, wherever we are in the forest. So that's my little 2 cents.
I would like to explain, Dan, the difference between fractionation and dose.
Uh-huh.
He's probably talking, I don't really know. By going from 2 to 3, he could be talking about a 50% higher radiation dose, or he could be talking about the same overall dose broken into 3 fractions rather than 2 for his own convenience, whatever he was referring to there.
Absolutely. And I'm so glad you popped in, because the issue I was bringing up, based on what Rick and others have said, I questioned whether he needed the spacer. And he said, give me time to look at everything. And so what he was indicating, and I think he's hesitant to use the spacer, and that's what he's doing is revising it to 3. So it makes it a little easier for himself. That's my interpretation.
Yeah, he may be reducing the dose since he's not using the spacer. I mean, Mac does not use the spacer, and he does this treatment in 2. He talked about that quite a bit actually in his presentation. He also made a point that if he was just giving regular old SBRT to somebody who was, say, intermediate, that most people do it in 5 sessions. He does it in 4 sessions. And he openly said they do it in 5 sessions because they can bill more doing it in 5 sessions, either for their time, basically. They bill more for their time. That's how he explained it. So I don't, but the explanation that of maybe, and that's the question to ask him. Am I getting the same amount of radiation, but just getting it over 3 fractions?
Right. He indicated something about 50% gray, and it needs to get up to 75 or 80% with the SBRT.
I don't know. I don't know. I mean, and again, I mean, I know what grays are. I mean, the bottom line is how many grays is he giving you how many grays would he have given you in the 2 treatments, and how many grays is he giving you in the 3 treatments? And if he's giving you more grays overall, then you have to ask him, well, why am I getting the third treatment? If he's just designing it better because he's taking you into consideration, then I would say that's fine.
Okay, thanks.
When I had
Yes, your hand.
SBRT on my
Yeah,
spine, they did it in 4 because they wanted to use less radiation in each one, that it
Right,
could possibly do less damage.
right.
Since
Yep. And that feeds into the spacer too. He's always indicated that the spacer is really to protect the other organs, but with lower dose on the radiation, he feels a little bit more comfortable. And maybe because he doesn't want to use the spacer.
Don, your hand is up.
more.
Oh, can't hear you, Don.
Yeah, you mentioned that you wanted to actually look at your scans and have an explanation of what's wrong based upon the scan. What I have done successfully 2 or 3 times is I make an appointment with a radiologist, the person that actually read it, and I do it online. They bring it up on the screen. They share the screen with me. They actually describe it there. Understand one thing: these people, these radiologists, people that are reading the scans and the X-rays, they are your doctor. You're the patient. They're your doctor, and don't be afraid to do that. I have found it to be very, very beneficial.
Will Medicare cover that, Don? If you
Yes,
choose,
yes.
to have a radiologist of your choice, whoever read your film, do so, and they send a bill to you, does Medicare cover that?
Medicare covers it.
That's good to know.
Thanks, Don. Thanks, Ben.
Okay, Dan. Next up is Dennis Correa.
Yeah, just another shout out for the intermittent treatment therapy. Uh, last week I mentioned what was going on with myself, and the PSA was shooting up quick, and I had an appointment with the doc, and about 3 weeks ago now, let's see, I had was my started the back on the Eligard after about 10 months of vacation, a holiday, Eligard and Nubeqa. And my PSA has dropped very quickly. Uh, it's always a little apprehensive at the end of the drug holiday when the PSA starts rising, but I felt good about it. Dropped down to 0.35, which also kind of indicates I'm still hormone sensitive, which is a good sign. So just for anybody out there considering the drug holiday thing, as to all the discussion we've had
Hmm.
about it, I can understand the apprehensiveness that you have, but it's working for me, and then the data and so forth seem to support it. So I'll keep doing it as long as I can. And
Makes sense.
no side effects from the Nubeqa compared to when I was on Abby. A big difference. Uh, so I felt so good about all this. I went out and played 18 holes yesterday.
Oh, and
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 I won the close to the pin shot for the group, for the group, and put a little more money in my pocket. But
great.
my score is still, and I'm not hitting the ball as far as I used to. So, but that's okay. At least I hit it straight. I stayed out of trouble for the most part.
And were you so enthused with so much energy that you decided also to give another coat of polish to that? What is it? Your 917, or I never remember the number. 921. What is it?
718. 718.
718.
Yeah. No,
Did you give
not
another
yet.
coat of polish to the 718 yesterday as well?
No, I came home, took a shower, and took a nap.
Okay.
It was about 100 degrees when we finished up yesterday, about noontime.
I was
So,
going to ask what time of day you played because it's been 105 and whatnot.
yeah,
What
we
time
were
of day did you start that 18 holes?
up in Oro Valley, El Conquistador. It's it's a pretty hilly course, so it was a workout. I mean, yeah, even with a cart, every tee box is elevated, so you got to climb up to the tee box, and then many times you got to park quite a ways from the green, and the greens are elevated, a lot of elevated greens, so you got to climb up the greens. Just lots of
Huh.
hill climbing up and down stuff that just kind of worked me out. My legs and my low back was acting up a little bit, so but feel good today.
I will tell you, and I think Dr. Mark, looks like Dr. Mark is on here somewhere. Oh, there he is, right at the bottom. Hi, Dr. Mark. I will tell you, it was probably warmer in Los Angeles than it was in Tucson. In Tucson. So,
Really? Wow.
yes.
Wow.
Is this 1718 a Porsche? What is the
Yes.
718? Ah, okay.
718 is a Porsche.
It's a mid-engine two-seater Porsche.
Yes. Mr. Muslin isn't on, but he would be one person appreciating that, we know.
What year is the Porsche?
2017.
My son has a 911 from 2002 and wants to go back to the 90s. But just like ED, for every 10 years, you increase the price 10%. We heard yesterday for every 10 years of age, whether you have prostate cancer or not, you increase the risk of ED. Porsches are like that, except it's just the opposite in price.
Yeah, their tailpipes tend to droop when they get too old.
I had a 911 SC for 40 years. I finally
Whoa.
sold it. I sold it this past year. It was hard to let go of. It was like a part of me. I loved it. I loved it, but it's high maintenance, really high maintenance.
Yeah.
My original cost in 1982 was 32,000. I put over 32,000 in repairs, and it's not reliable. You take it on the road, it breaks down. You got to get towed away.
Yeah, you do all that required maintenance, even though it seems like it's running fine. And if you don't do it, then you could be looking at some big, very costly repairs.
Good to know a good German mechanic. Pay him on the
Yeah,
side.
you got one.
Anything else from you, Dennis?
That's it. Thank you. Oh, Ben, thanks for that nice write-up on the DLL and the neuroendocrine stuff
Ah,
work that's going on. That looks that's the most promising stuff. I mean, we've kind of heard about it before, suspecting, but now it looks like they're making a lot more headway towards the ability to detect it and to possibly even treat it.
yes, exactly. Yeah,
Oh,
yeah.
and I have a mea culpa that Ben pointed out to me as well, which is that I thought that the research that was being done at MSKCC by Dr. Morris and the Italian lady PhD was also the same part of the same work that Misha Beltran was doing, but Ben pointed out to me it is different, but I think they're working pretty closely together. She's working with a bispecific molecule that's targeting neuroendocrine genes that express DLL3, but they are able to test for DLL3. I don't think they use this photographic, this imaging that Memorial Sloan Kettering is doing, but they have some sort of a lab test to see if you express DLL3, but it's not commercially available. Is everything I said okay, Mr. Nathanson?
Oh, I'll take it on faith.
Okay,
Um,
thank
Thanks,
you.
Dennis. I appreciate your
Was
stand-up.
that, were you guys referring to a new blog post of Ben's that I missed? Or what was that?
Not a blog post. This was in the reminder. I
Oh, in the reminder. Oh, gotcha. Okay.
snuck in a little news item. Steve Rue, you're up next.
Okay, so feeling pretty down by the fact that some folks are playing golf in 100 degrees when I'm sitting here at 78 in Upper Michigan with a golf course right across the street from me, and I'm still sitting on my ass and the clubs are in the shed. You inspire me. I think I might get out there tomorrow. So I heard somebody mention already Medicare, and this is one of those cases of the clever boy who has just outsmarted himself. So I have a birthday coming up at the very end of the year. I'm blessed with one of those end of December 30th birthdays. When I started on the Orgovyx and the Abbey, I kind of set it up intentionally so I was getting my prescriptions the first week of the month. Well, it turns out that when my Medicare kicks in December, it's not December 30, it's December 1st. So at the very end of the year, I'm going to have to pay out of pocket for 2 of those prescriptions, and they tell me that's going to run about, depending on which Advantage plan I pick, $2,800 to $4,500 out of my own pocket. And I won't be able to use that out of pocket towards the 2025 maximum out of pocket satisfied. I talked to somebody that said that there's possibly some assistance for the Abbey that Medicare will accept or apply, but I haven't seen anything on the Orgovyx. So, short of trying to call them up in November to tell them, horror of horrors, I was washing dishes and the whole bottle of pills fell in the sink, and ask for another refill, which honestly, that's an option. See what they say. But I'm curious if anybody has Medicare who's getting either Orgovyx or abiraterone, where they're getting some pharmacy or whatever, some manufacturer's assistance that's accepted by Medicare. Because I really don't feel great about spending $3,000 right at the end of the year
Yeah.
out of my own pocket for 3
Look,
weeks of insurance.
one problem you're going to have, Steve, is that a lot of this assistance runs out by the end of the year anyway. So even if you're eligible, they don't have it because they allocate so much money through the foundation programs and they get rid of it. Now, the direct programs through the drug manufacturer are funded differently. The programs that are funded through the Patient Advocacy Foundation and all of those different ones, I forget the names, that's actually money that comes from the pharmaceuticals, from the pharmaceutical companies, but they're not allowed to sort of give it out direct. I don't understand the rules. They're really, really complicated, but for certain things they cannot give it directly, so they give it to the foundation to dole out. For other for other drugs, and I think it's usually their own drugs, that they can subsidize, but I don't know. Some of the guys might know here, but what I will say is when you wait till the end of the year, it's very hard. I mean, the other issue that we probably should talk about is, are you absolutely sure that you want to get into bed with an Advantage plan? Because it's going to heavily restrict the doctors that you can see. I'm on an Advantage plan, but I'm on there for a reason, because financially I've thought it through. But that's a whole separate discussion. So I think we should probably answer you first about the drug plans, and then we should maybe talk about what's the best type of Medicare plan for you.
So we
I'm
have,
currently I'm currently looking at two. One is Priority Health, and the other one is Blue Cross for the area that I live in. The Blue Cross covers the entire damn state. It doesn't look like it's too restrictive about anything. They're both PPO plans.
So,
I don't
for
know if that
example,
helps.
does the Blue Cross give you access to University of Michigan?
Yes,
It does.
yes,
And to Carmenos?
yes.
Okay. So, I think if you've got that, it makes it harder on you to get second opinions. If you want to go out of state, that's not going to be covered, but that hopefully isn't going to be the case. And I think you said you found a GU medonc who was trained by Dr. Heath, who's local, who you like as well.
Yes. I mean, he's not technically GU, but he was, handpicked, hand groomed by Dr. Heath. So
Okay.
he's got a little more going for him as an oncologist than others would for, prostate specialists. Uh, you know, a secondary line of questioning would be, has anybody has experience with or heard about results of the results of taking one dose of abiraterone with a meal as opposed to being on an empty stomach, and that is another option that I'm exploring.
Yeah,
Right.
that's a great solution.
I mean,
So,
just to
so
try to get through
let's
that month.
right. Ben, why don't we throw all of that out? Because there are going to be guys who want to talk about taking Abby with food and guys who want to talk about drugs. And I don't know. We got a lot of issues going here on the Steve Root track right now.
Sorry,
there are
guys.
three guys waiting to weigh in. Don?
Yeah, hi. I just got off 2 years of abiraterone June 1st. I got mine through a company, and I sent you a private message called scriptco.com. And it's about 75 or 80 bucks for a month supply. And it's a $50 quarterly membership fee. But anytime you need to get any type of generic drug, and all they have is generics, go to Scripto. Everything is amazingly cheap. You can't match it anyplace else. It's reliable. It was written up in Consumer Reports. I mean, I've been using them for 2 years. It's fantastic. The other thing too is that whatever you do, don't consider a Medicare Advantage plan. And we can go into this later, but it's all the copays, all the nonsense you go through. If you go with traditional Medicare A and B with a supplement, it's going to cost you a little bit more. But I'll just give you an example. I mean, the last 2.5 years, my University of Miami has charged Medicare, close to $500,000 for my treatment, surgery, radiation, the whole shebang. I'm out of pocket zero. I haven't paid 10 cents for my treatment at the University of Miami because I've got A and B with supplement F, which is no longer available, but supplement G is the same thing, and you're only out of pocket with supplement G for the yearly deductible, which I think is like $200 now.
I agree.
Ditto.
There
I'm
is a
Marcia?
I'm hearing that Advantage plan is really highly desirable here.
Look,
there is
I think that there are points that which Don says are right. There are points that need some comment and apply to everybody. When you choose a supplemental plan, it has a monthly out-of-pocket cost. For the better plans like G, that can be, depending on the area you live, anywhere from maybe 300 to 500. It varies. So yes, you only have a very small deductible, and yes, you don't pay anything extra, but you're out of pocket from the very beginning, somewhere between 4,000 and 6,000 a year, because that's what it's going to cost you. Now, you have to weigh that up against what you get with the Advantage plan, including access to which hospitals. So in Steve's case, he has access to Carmenos, where Dr. Heath has been, although she's not still going to be there. He's got access to a doc that she's recommending who he likes, and he has access to an NCCN center in Ann Arbor in the University of Michigan, where he's going to be limited in choice, but he can definitely find a GU medical oncologist. And for that, he's probably paying either somewhere between $0 and, I don't know, $20 a month for his Advantage plan. So it's not going to be very much. Yes, he's going to have a lot of copays. That's the situation that I have. What I did is I looked at what my G plan would cost me, which was going to be somewhere around 5 to 6 grand a year. I looked at the maximum out of pocket that I would have to pay before my Advantage plan picked up everything. And that was around $7,000. And I figured even if I go out of network, it's going to cost me 7 grand. And at that point, my Advantage plan is going to start picking it up. So I'm rolling the dice every year between being faced with having to pay $2,000 more than if I was on a G plan, or saving $5,000 a year. Now, my situation is very different because thank God, touch wood, I'm a lot more stable than you, than most of you. But at the same time, this is the math that you have to do. It isn't clear that an Advantage plan immediately is bad. It's an economic issue, and also an issue on who's in your plan. And if the hospitals that you want, the providers where you want are in your plan, maybe an Advantage plan isn't so bad.
Richard Tolbert, you have wanted to share.
Yes, Steve, I get my Orgovyx, and I have a a grant from a group called the Assistance Fund. And each December, they send out paperwork where, you fill it out and you go for the next year. So that might be an option for you to look at. But also, there's another group called the Copay Relief Fund that I've also got some funding from. And Sumitomo, you can go directly to them for the Orgovyx.
So Sumitomo is a great option. The problem with the first two is if Steve needs this to buy drugs in November or December, they're not
Yeah,
going to have any money left. They dole out all their money for come January, February, he'll be fine, but they won't have
right.
anything to give him for November, December. Going directly to Sumitovan for the Orgovyx, definitely an option, definitely.
I'm sorry, what was it? Sumo what?
The people that make Orgovyx, well, I'll put it in the chat window. Is it?
They're the
They're called.
manufacturer.
They're the
Oh, okay,
manufacturer.
okay, never mind. All right.
Sumitomo Pharmaceuticals.
Okay.
And if you just go to the Orgovyx website, it'll be all over there. If you need financial assistance, click here or there or anywhere. So you'll find it on the Orgovyx website, Steve.
Dr. Mark, you have had a number of things to say in the chat.
Yes, so I disagree with you, Rick. I switched over briefly, and my mailbox was inundated. Every day I spent hours trying to coordinate what I was getting from doctors' offices on EOBs and insurance companies and what my copays were. For me, the amount of money I paid and having in my case, I didn't have all the options that I want. In Atlanta, we had 3 or 4 upheavals when insurance companies changed who was on their panel. And if you are in an Advantage plan, it's nearly impossible to switch back to regular Medicare. And if your plan is with Humana, and all of a sudden Humana doesn't like University of Michigan, you're just out of luck.
That's true.
Yeah, and I switched to the low dose single tablet with meal, and my testosterone was always undetected with sensitive assays, taking 1 a day, and convinced my doctor to let me do that rather than 4. The other thing I wanted to mention in Michigan, there's a House Bill 4071 that basically, this is in a number of states now. I think it may be around 11, I'm not sure, but that oral cancer medicines must be covered to the same extent that IV medicines are covered. So that may be something that will assist in getting those medications for you.
That sounds great. Has it passed anywhere?
Yeah, in 11 states. It's
Passed
passed in
in
Michigan.
11 states.
Yeah,
Wow.
it's passed. It may be 9. There was so much stuff thrown at the meeting, but that was one of the things that went up. And I would look into that bill 4071, and that is a Michigan number, I think.
That's great. Thank you. Vic, you had something to say?
Yeah, I wanted to second what was said about not being able to get into a traditional Medicare supplement plan after Advantage plan. That can be a huge thing, especially later on as your cancer progresses and you want to get into, maybe you want to travel to see a doc at a center of excellence somewhere else. Maybe, maybe like was mentioned, your Advantage plan decides it doesn't like, XYZ. I heard one story about a guy who was with Kaiser Advantage, which is in California, which is like supposedly one of the best Advantage situations. They up in the middle of the year decided that anybody on Xtandi would no longer get Xtandi. They would have to go to Abbey. And it was just a blanket decision they threw out there. And so here's a guy who's been on Xtandi for 7 years, working great. Now all of a sudden they're telling him, nope, you can't have it anymore. You got to go Abbey. And that's the kind of thing that Advantage plans are kind of notorious for doing. And you don't want to be fighting with your insurance company later on in the later stages when you're already fighting a tough battle anyway. So that, to me, that's one thing to consider.
I mean, Vic, I will say one thing from what you just said, which is a nuance that probably you're not expecting. But any oncologist who left a man on Xtandi for 7 years without an interruption, without some sort of change or break, To me, that's criminal, because when that Xtandi stops working, nothing else is going to work for him. And so I hope it keeps working for another 7 years. But they did him a favor by moving him to Abbey.
Yeah,
You know,
but it wasn't on purpose.
but that's the problem with Kaiser. Kaiser is a great system, provided you want to deal with community medicine. If you need anything that's special or above the standard of community medicine, you do not get it at Kaiser. What you get at Kaiser is standard of care. Now, there are a few exceptions. Jeff Marchie's going to tell us about. As he had his hand up, we navigated Jeff to a very good genitourinary medical oncologist at Kaiser, but they're few and far between. They're very hard to find. At the same time, somebody was asking before early in the chat window, Steve L. He can't get a second opinion at the same institution. At Kaiser, you can. Kaiser, you can get another Kaiser doc to give you a second opinion. I don't know if they have a conflict of interest in doing that or not. It's a question I would have to ask. But most institutions, if you're going to go get a second opinion, they send you somewhere else, which is really where you want to go. But Kaiser, to me, is not an exemplary advantage plan. It's comprehensive, but it's not exemplary.
Yeah, I'm not trying to represent them as being the choice I would make, but rather
Right.
just what I've heard from people who've used it. As far as most Advantage plan goes, most people that have been using it seem to rave about it as, oh, it's been great for me. But, that's just anecdotal, what I've heard. So, but I would say that, I have heard a lot of people that are in later stage, when things get more difficult, who are fighting with their insurance company. But if you got a supplement, there's no fight. If it's FDA approved, Medicare covers it. If you have a supplement.
So I see some hands are still up. My inclination is to move on, but if anyone who is waiting, Dr. Jeff Markey, Don Rogers, has something they feel they need to add to this, you can do
Yeah,
so.
I would like back in August of 23, when I was originally put on abiraterone, um, I researched the price before I knew if it would be covered, and the generic abiraterone ran about $9,000 for a month. Um, I was subsequently covered, and now I'm in a state where it's questionable again. And so Janssen, the manufacturer of Zytiga in India, it costs $240 a month for 120 pills of Zytiga. So I may take a vacation to Mumbai and buy a year's worth of Zytiga at $240 a month, which is significantly cheaper. Even if you do one pill of abiraterone, that could still run thousands of dollars, where the real deal Zytiga is $240 a month. And I mean, that speaks volumes for what goes on in this country, and how we get screwed on prescription drugs.
Someone mentioned Scriptco, and they want $75.89 for 120 abiraterone pills a month. $75.89. So definitely can get the generic for a lot cheaper. SCRAPTCO. Also, I don't know what the story is about Kaiser blocking off Xtandi. There's absolutely no problem getting darolutamide with Kaiser. If it might be they cut him off of it because of what Rick was saying, that he's been on it too long and they need to switch him. They're worried about neuroendocrine or some other issue. But I know that my oncologist wanted me on Xtandi first, and I talked her into letting me have darolutamide. And there was no question I could get either one at Kaiser in San Francisco. So I'm a little puzzled about this statement that they don't allow it.
So I'm ready to pound the gavel on people versus Kaiser and move on. Um, as Tony Fig has been nice enough to put in there's so much that can be said about this, and a lot has been said in it and is in an AnCan webinar. Tony was kind enough to put up the link where some of these things are discussed for anybody who's in the throes of decision on this. Um, moving on then to Brian Hack.
Can I just throw in one thing real quick? I've already
Yes,
met
Steve.
with I've already met with two specialists, for Medicare plans and Advantage plans, and research some of the supplemental things. And I just got to say, with all the knowledge that I got from those folks, two different outfits, I got more information here from this group than those two combined. So I just want to say thank you to everybody.
Yeah, I mean that's definitely true. A lot of interesting stuff, a lot of useful stuff was said. Thank you, Steve. So Brian, you are next.
Yeah, I completely agree with Steve. So my situation, for whatever it's worth, I have recurrence. There's lymph nodes involved in the retroperitoneal, and they want to start me on a doublet therapy, ADT and a ARSI. And I'm just wondering what besides that, I that was a one trial, clinical trials. Then came I'm trying to remember all these names. The arsons, where they added doxycycline to the doublet to make it a triplet, and we're talking intermittent therapy. I wonder if anybody had any experience or opinions on triplet versus doublet.
I was wondering, Brian, whether you ever got to see Dr. Reddick, who will be part of this decision.
I'm seeing Dr. Ryder, and he is he's a pretty good person, so I didn't change him, but I do have a appointment made to see the radiation oncologist. His name was Kishan, I think. But Reddick is,
Kishan, yeah.
yeah. So I've got an appointment to speak with him, and yeah, I didn't really talk to Dr. Reddick. I just left it in the hands of Dr. Ryder, who I think is considered pretty good.
No, but Dr. Ryder's a urologist, Brian. That's what we pointed out.
Oh, okay. All right,
And
then I'm gonna have.
the reason we want is because we don't like, even if their name is Shore or Kwan,
Yeah,
we don't like urologists meddling in advanced treatment because they think they know what they're doing. And we've seen
right.
too many instances where they don't. And so the reason we said chat with Dr. Reddick is because, yes, Kishan is definitely a very fine radiation oncologist. But this question you're asking us, doublet versus triplet, if there's
Mhm.
any nuance to it, then he's the guy. Now, in general, it's not a difficult decision. It really depends on how many metastases they see. And just remind us, how many Mets do you have?
Two, one on either side of next to my kidneys. So it's
Okay,
at the retroperitoneal level,
right. So it's
kidney
a
level.
no-brainer with you
Hmm.
because the recommendation is not to add chemotherapy. However, there may be certain exceptions. Have you had any? I don't have your record up. I'm just filling in some stuff on
That's
Steve.
fine. You're doing a great job, Rick.
Um, Let me see. Have you had any next generation sequencing yet?
No,
Okay.
no.
Excuse
So
me, he had genetic testing and no genomic testing, and his
right, no,
genetics are
that's what
clear.
I'm saying. He hasn't had NGS. He hasn't had any next generation sequencing. He's just had germline. So it's
Correct.
very, very important that you get that underway. One thing that I learned in a webinar, I learned, as did Dr. Mark, because he was watching the webinar too, is that if, God forbid, you were to have a PTEN mutation, and PTEN mutations are not, I don't want to say they're common, but they do occur in de novo men. That's PTEN. That if you had a PTEN mutation, they might treat you as if you were castrate resistant, even though you were just starting off on the drugs.
Mm-hmm.
Because what we've seen is that men with PTEN mutations should be treated as if they were castrate resistant. And then that changes the sequencing, which is why it's so important to get, and you probably won't, we hope you won't, but we've had people who on diagnosis were sequenced and I'm thinking of Herbger, rest his soul, who was PTEN, RB1, and ATM. And we're learning more and more every week about what the implications of these mutations are, which is why we want you to get sequenced.
All right, copy that. I am trying to like find a new MO here locally, and so it's just been a couple, bumps and ditches and stuff like that I had to navigate. But I appreciate you reminding me why Reddick was a first choice. So I appreciate that.
I saw Reddick on Sunday,
Oh, is that right?
and I went up and made a point of just talking to him and making sure he knew that I was from AnCan, and I mentioned a couple of other guys who he's seen recently, Jeremy, and who's here tonight, and older guy who lives out in Ventura, and others. And so he knows who AnCan is. He's supposed to be really good. Jeremy, you liked Reddick when you saw him, right?
Oh yeah, very much.
Well, that's a
Yeah.
no-brainer.
But
Yeah.
I would expect doublet, and probably I would expect, hopefully Orgovyx, but an LHRH, and probably abiraterone is what I would expect. But that I'm not advising you, but I'm saying that
Yeah.
would probably be where you go. Dr. Mark, you got your hand up.
Yeah, I just wanted to ask quick, Rick, where do people get tests for that? If they're doing immunohistochemistry, they can only do one assay at a time. But you're
Right.
talking about RB1, PTEN, and some of the
Right,
others.
right.
What would be the best place to use to get that?
So it's up to who orders it, but we tend to. The companies that can provide it are companies like Foundation Medicine, Tempus, who is particularly we like Tempus a lot. Caris is another. Myriad definitely can do it. Can do it, but the only company where we've run across issues, some of our medical oncologists have, is Guardant. I don't know who, and then some of the hospitals will do it themselves. But I would say send it out because it's quicker and probably as if not more reliable. So that's what I would say.
Can I ask a follow-up question real fast? is Orgovyx like Firmagon, where you do not need to? It's like an antagonist versus an agonist, that it doesn't cause that testosterone flare. Is that correct? Okay. Orgovyx for sure. And then if they want to go to Eligard after a couple months, I would be open to that too. All right, good to know.
The good thing about Orgovyx, and some of the guys here have experienced it, is that if you can stay on it for as long as possible, it's pretty amazing when you come off it. I mean, we ran across somebody who'd come off Orgovyx 3 months ago, and their testosterone's already back up to 300. And you just don't see that. You don't see that with the injected, with the depot drugs, whether it's with the agonists, and you don't really even see that with Firmagon.
Interesting. Yeah, I've never tried Orgovyx, but yeah, what you just said has been what's been reported. I wonder though if a gradual return of your testosterone might not be a little more gentler on your body when you just, I don't know. But anyway, thanks for that, Rick. Appreciate it.
You know, if you ask most of these gents whether they'd like to have a level of 300 or 400 within 3 months of getting off, I think they'd all put their hand up. I don't think they'd be too. I don't think they'd be too worried. I don't know. We could do a straw poll, Mr. Nathanson.
Except we don't have to. We already know. Okay, is that it, Brian?
Yeah, that's all I had tonight.
Thank you.
Appreciate it, guys.
Excuse me, Brian. This is
Sorry,
Jim.
Jeff. That's right. Your hand was up.
Turns out I have exactly what you have. The exact ones. Okay. And let's see, I was on Lupron plus the Zytiga for 5 years, and I'm on a 2-year holiday. So as I said, that was a choice at that time.
Okay. Yeah,
So,
I don't know. I think they were talking 9 months, but we'll see. It all depends on how well I respond to the ADT and inhibitor.
well, responding wise is your PSA will drop. Okay,
Right.
and it will stay down. Now, if you're off of it, it will probably start to rise essentially over time. So,
Yeah, I mean, we're talking about intermittent ADT, so I don't know how many months intermittent means.
okay, anybody?
Jim, can I ask you a question?
Sure.
Jim Marshall, why were
Yeah.
you on 5 years of doublet therapy rather than 2 or 3? Where does the 5
Because at the 2-year point, I wasn't here. I was here at the 4-year point, and along the way, they started to talk about it here off and on, and then they started to talk about it, I think, about the 4.5-year point, and then there was another study done that said because if you stay on it too long, there is a chance of the small cell, and that captured my attention. So I decided to take a break then. But it's evolution.
Brian, what's your Gleason score?
Brian, in terms of your question, Brian, about what does intermittent mean for somebody like you, we can only guess what your oncologist is going to recommend. But with grade group 5 pathology and metastasis, I would probably expect something like 2 years on the ADT.
Yeah.
That sounds about right.
Yep. If it was a Gleason 7, you'd have 9 months.
Well, it was a Gleason 8, so.
Yeah. That's 18 months usually.
I was
but it included
but it's
some.
a 5
It
plus
included
3.
some grade 5 pathology, Jeff.
Yeah, 5 + 3. Yeah,
Three,
gotcha.
3 + 5. Yeah, exactly. And
Oh.
yeah, that high volume.
Not high volume, high risk.
Well, what I mean by that is the cores were 50 and 90%.
Oh,
Oh.
okay.
But yeah, that's it.
Thank you. Jim, sorry to miss you before. I'm going to jump in. So Vic, you're next.
Yeah, quick update without any history. Had my third round of Pluvicto, met with my radonc today to go over the scans. I get a SPECT CT scan 24 hours after each administration, and sat down with him today to look over all three scans. Had very strong uptake in the first round, and as of the third round, the uptake is much reduced, which seems to, and we're looking at broken up, you know, PSMA lesions, reduced size, stuff like that. So looking very positive for that.
Um, yeah, there was some other interesting discussion. Dr. Dorff raised this in one of the breakouts. Is that, and I think Dr. Heath mentioned it too, that Pluvicto is approved for 6 sessions, but you don't necessarily need 6 sessions. And the doctors who aren't comfortable with them, especially if they're not a GU medonc, might say, "Oh, yeah, just push you through 6 sessions." But if you can get away with 4 sessions, there's nothing wrong with that. And as Tanya Dorff said, if she's got patients who are doing really well and she doesn't see anything after 4 sessions, she doesn't give them the last 2 sessions. What sort of reduction in the metastasis, Vic, have you seen in your case from when you started to now after the 3 treatments?
Well, it'd be hard to give you a percentage because I've got widespread, and it's it lit up all over the skeleton and skull. Principally, what he was pointing out today is there was a pretty strong area on the spine that lit up that is almost all gone at this point. There was another lesion that was up near the collarbone area that was large, and it looks like it's broken down into 2 smaller lesions at this point. Some lesions on the pelvis have shrunk in size. The the scan is so what do you call it? Specific. It shows so much. I don't really know that all of those things that light up are really actionable, but there definitely seems to be a fair amount of shrinkage and less places lighting up.
Did you're still at Siteman, correct?
Yeah. Yeah. Well.
And did you ever switch to a genitourinary medical oncologist there, or are you still seeing Meehan?
Well, Mian's my MO, but I'm working with Prasad at Mallinckrodt Institute of Radiology. He's the director of the diagnostics division.
Right.
He got he cut his teeth in Germany with Pluvicto during his fellowship, and then he was recruited to come and take over the diagnostics division at Mallinckrodt.
So, I mean, and this is sort of where we think the knowledge of the GU medical oncologist comes in, because therapeutically, Prasad just doesn't have the feel or the experience that a good GU medical oncologist had. He knows it's prescribed for 6, so he gives 6 because that's his job. Because he's a nuclear medicine doctor. But there needs to be input from a knowledgeable GU medical oncologist, which was one of the reasons why we suggested back in the day that, switch to, say, somebody. I have the names of Aurora and Picus, who are 2 of the people, but that's where your Tanya Dorf or your Elizabeth Heath or your Eleni Evstathiou, this is where they come in and say, you know what, maybe we think you shouldn't get any more right now. Because if you do too much, there's a bunch of reasons why. A lot of it has to do with side effects. A lot of it now has to do with how much we can give you next time, because we are repeating this. So if we only give you 4 now, it's more likely that we're going to be in a position 2 years from now, if we need to repeat it, to be able to do that. So that's why we're pushing this issue of get some second opinions on how many, get other people reading your scans, not just the radionuclide doc.
Yeah, that makes sense. Definitely. It's been on my mind to get that second opinion, for sure. And, most of the GU medoncs that you recommended are both in the same system here. I can definitely, won't be a problem getting a second opinion from one of them. I can definitely go there, or I could even, Rochester isn't that far away from where I'm at. I could go to Mayo too, and seek out second there.
Wait until October and get yourself in as a patient of Dr. Heath. I mean, if you're willing to go.
Is Heath going to Mayo in Rochester?
Yeah, Elizabeth Heath is going to be the head of medical oncology, all medical oncology, not just GU. She's taking on the job as chief of medical oncology at Mayo Rochester.
Okay. Well, I will. I'll definitely reach out and see if she will give me a second, and maybe
she'd be a great person to have on your team.
Yeah, thank you. Yeah, I appreciate that recommendation. Yeah.
You mentioned getting SPECT scans after each administration. Is that typical, or are you in a clinical trial with Pluvicto? I never heard guys mention that before.
Yeah, it is. It isn't, I guess, traditional standard of care with Pluvicto. This guy, he started out in Germany. That may have been the way they were doing it there, and it's the way he does it. He also is going to set me up for a bone scan after the next treatment. So for comparison's sake, against the SPECT scan, SPECT CT, and so that's another thing he's going to be looking at. So I think that'll line up pretty good for me. My next scheduled therapy, number 4, will be at the beginning of October, and with that, armed with all 4 imaging from the treatments plus the bone scan, I'll have good information, I think, for Dr. Heath to
that really caught my attention too, Len, when he said SPECT CT scan. Like, what is that and what does it mean? And is it a great way to follow the progress of Pluvicto? I think it'd be nice for us to learn a little bit more about that, especially if, as Rick says, it can save somebody a couple of treatments.
Yeah, this is stereo PET. So they're rotating the PET all around so that they can twist it 360 degrees and look at it from any angle. And so they do head, torso, pelvic, femur with that full 360 rotation PET, and then they do a full body CT scan after that's done.
So
And I know that is kind of unusual. You don't see that generally, and I'm not sure if that's because this is how he was, how they were doing it in Germany. When he was doing his fellowship work there, or, he not sure about that.
So this is neat. From your SPECT series, you can see this thing breaking up like a first-person shooter game. That is really cool. So as far as I know, the SPECT scans use gamma radiation, which you're getting from the Pluvicto, and the definition is not as good as an ordinary PET scan, but you already have the source in the body from the lutetium.
Yeah, he seems to feel it's a good way to measure uptake. He does it 24 hours after administration.
Nice to see you again, Vic.
Yeah.
Yeah, thank you.
Yeah.
Good to see you all too. Thank you. Appreciate it. Rick, I'll probably reach out to you for Dr. Heath's contact information if you don't mind.
I don't have it yet.
Okay.
I only have her information. Here's what I would suggest you do. Okay.
Okay.
Because I only have her Carmenos information. She just wrote to me this week. I would call Mayo and say you want to make an appointment with Dr. Heath. You understand she's going to be there in October. They'll know when she starts seeing patients, and just go in that way. Go in directly and say you want to make an appointment. Now, Dr. Sartor's there too. You could also see him because he's probably the best GU medical oncologist in terms of technically grasping radionuclide therapy. So he's another very, very, very good person. But I like Heath because I feel she's more all round. She probably isn't as good on PSMA and radionuclides as Dr. Sartor, but Dr. Sartor's there already. And I think I can give you his information if you want it. You got two really good choices at Rochester.
Yeah. Well, if I'm going to have somebody cut my sessions, I'd probably prefer for Sartor to do it. He's very, very well respected, I know.
Yes.
Got quite the reputation.
So go after Dr. Sartor. I'll tell him you're from AnCan. I'll send you his email right now, Vic.
Yeah, thank you so much. Appreciate that, Rick.
Hey, Rick, quick question. With this position for Dr. Heath, what will be the supervisory relationship, if any, between her and Dr. Kwan?
Much the same, I suspect, as it is right now between Sartor and Kwan. He doesn't refer to Sartor. And we had a discussion about that, and she may follow up with me, but I don't know. I mean, I had a guy come up to me after one of those sessions, and people have been asking for docs' names. And he came up and he said, "Who would you recommend?" "Oh, I live in Nashville." I said, "Well, who are you seeing?" He said, "Dr. Kwan." I said, "Well, you need to get your ass out of there right away." And he said, and he looked at me and he said, "Well, what's wrong?" He's this, he's that, he's the other. I said, "He's the wrong doc." I said, he doesn't even use his own facility for chemotherapy. No, he told me there's a very good chemotherapist that he uses in Minneapolis. I said, exactly. I said, he doesn't even refer people who need chemotherapy to people in Mayo. I mean, one thing I can pretty much guarantee is we won't be seeing Dr. Kwan and Dr. Heath on the same bill at PCRI. But as far as Dr. Kwan is concerned, I don't think he gives a damn who's there, because he's going to do his own thing. And patients who are duped by that, you know, they've got to keep their eyes peeled. They've got to be aware. He ain't going to get me.
Thanks.
So this is a personal communications. Richard Tolbert has left, but he messaged me. He asked me to ask you, Steve Rue, to check a message that he left for you in the chat to make sure that you saw it.
I did, and I replied
Okay.
to it. I don't know if he got it before he left or
Oh,
not.
okay. Very good. Thank you. And end of digression. So, Steve L., you had reconsidered your initial decision not to talk to. Were you able to get the answers you needed in the chat? Did you still want to speak?
No, I was looking for some sources for a second opinion. My primary care is through Yevzefsky at Fred Hutch, and I had tried to talk to another guy at Fred Hutch, but was turned down. And is there anyone that's recommended in Seattle? It's Swedish or over at Virginia Mason?
I don't know. I'd have to do some research into Swedish. I do think they've got one or two people. But I have another idea for you if you're willing to travel but not too far.
Yes, I'm willing to travel. San Francisco isn't that big a flight, yeah.
Okay, well, just by how quickly do you need this?
There's no urgency.
Okay, bide your time, and you're going to have one of the very best options that we could offer at OS. I suspect at OSHU before too long.
Okay, good. And I have not had any slightly different question. I haven't had any radiation to my primary or my Mets. The Mets are limited in number and fairly small. Is there some category of metastatic patient that treatment wouldn't be appropriate for?
I'm not sure I understand the question, so I'll pass it along to one of the other moderators.
I'll ask it directly, a little differently then. I have not had, any radiation of my tumors, and it's been sort of recommended from time to time, a reduction. Is there some subcategory of patients that would not be appropriate for?
Well, I think your question is, when do we use spot radiation?
Yes, okay.
And one of the raps with against Kwan is that he manages everything with spot radiation, which he does. Now, there are times when the disease has recurred, and we think that just with a little spot radiation, we can have a significant impact, so you don't have to go back on systemic. But we don't use it in place of systemic, which is what Kwan tends to do. we'd like to see, I don't want to say we, but medical oncologists that we trust and respect often recommend using a little bit of radiation before they're doing any treatment that might involve any form of immunotherapy, like Provenge or maybe like Keytruda, because we think that there is some synergy between the radiation, which kind of tunes up your immune system, and then giving a drug that is utilizing that immune system, although Provenge and Keytruda do it in very different ways. So again, I think I got to refresh myself on your
Steve is
situations.
already on Provenge, I think.
Yes.
Right. So if you had a spot, and yeah, I see you did Provenge. If you had a metastatic spot, certain doctors that we know would have said, let's radiate that spot right before we start the Provenge. And Yosefsky didn't do that, maybe because he doesn't believe in that, maybe he doesn't think it's relevant. But there's no real evidence for that. But this is anecdotal based on how these doctors treat. They think you get more bang for your buck if you radiate first. But I don't know, where are these spots that you're talking about?
One on a femur and one L3, both pretty small.
Yeah, I mean, again, they may not need radiating, and you're doing some other stuff right now, and yeah, I don't know. I mean, Yosefsky should be on top of that, but I mean, for example, if you went to Dr. E, and although she wouldn't give you Provenge because she doesn't like Provenge, but if you went to Dr. E and you were going to get Provenge, she would say, okay, let's radiate the femur before we start the Provenge because it's going to do a better job for the Provenge. That's her theory. And there are other people who believe the same thing.
Okay, thank you.
I mean, this is where, go ahead, somebody else talk on this one,
Well, that
please.
was me. What about that shortness of breath?
Yes, it's been 6-7 weeks now since the pulmonary embolism, and there wasn't much change for 4 to 5 weeks, but over the last couple weeks, it's like the clots are getting smaller to the point where I'm getting more blood movement through my lungs, more oxygenation.
Can you breathe better?
Yes.
Good. Back pain?
No. No, but I had some back pain at the first infusion, which both sides could have been kidney pain, possibly. I thought it was back pain, but yeah.
Any more for Steve?
Well, I guess on the Pluvicto, the requirement for having chemo first, does that look like that might be changing?
So apparently, the the P4 or Pluvit was the test called for
Oh,
what's the trial?
PSMA 4.
Yeah, the
PSMA 4.
PSMA 4 trial, and there's another one too, and again, a lot of talk about this over the weekend. They're supposed to be reporting next week. Now, once they report, it's then going to take at least 2 or 3 months, and maybe longer, for the FDA to approve it. But one point that I made in the session with Dr. Dorf, and she wasn't aware of this, is that there was a poster. A poster is before a paper. It kind of reports a trial or an experiment before you've actually put it out officially. And there was a poster at GU ASCO that showed that if you did chemo before Pluvicto, the chemo was likely to be effective and didn't really change the Pluvicto. The Pluvicto was going to do what it was going to do. If you did chemo after Pluvicto, the chemo may not be effective. So if you want to do chemo, and this was a small study, I think about 55 people. I have the study if anybody wants it. I have not the study, I have a copy of the poster. So if you want to do chemo, it might not be a great idea to leave it till after Pluvicto because you might not get any benefit from it. And this was, like I say, only about a small study, 55 people. It was done at McGill in Canada, in Montreal. But, Dr. Dorf was very thankful that I pointed out. She said she had missed that one. She hadn't seen it. And we just don't know enough about the sequencing right now. So nobody wants to do chemo, but at the same time, it can be a very effective drug. And you don't want to mess up the opportunity for it to work for you, because then you've just lost a piece of armory in your arsenal.
You have any more, Steve?
No, that gives me enough to think about and do a little more research. So very good.
Excellent. So Bob Pethel, I'm sorry you've had to wait. Did you want to share something with the group?
We can't hear you, Bob, if you're there. Your screen is black. Your microphone is white. And your name's up there, but we can't hear anything from you. Send somebody a message. Or I'm not sure. Oh, now you're muted. Try unmuting again. Do you have that's good, but obviously your microphone isn't working. Have you selected the right microphone? So you go up to the cog wheel in the top right. Click on that. Click on microphones and make sure that you selected the right microphone. Failing all of that,
how's that?
Speak up. Oh, we got you. Great.
Okay, I selected the one for future knowledge, default microphone, USB. So I guess that's what I needed to do. Maybe I can get the video on too. I don't know. But anyway,
yes.
we'll go forward because I know it's getting kind of late. Since I didn't have the score for my 2013-14 episode when I had a cryo procedure done last week, we kind of closed things off until I could find that, and I did. It turns out that it was a 3-4.
Okay.
And you might remember that this last current go around, it's a 4-3. So I've got 5 of 12 cores that showed up this time, 3 of 12 cores the last time.
Okay.
In January January of 2014, I had a PSA of 9.2 when the treatment was being considered, and in April of this year, it's at 9.6 for the new or anything I'm considering at the moment.
Okay. And where are you? I mean, are they still discussing surgery or radiation, or have they moved on just to the radiation therapy?
Just to the radiation, thanks to your comment the last time we visited, Rick, because you were absolutely right. It should have been probably on the table for me anyway.
And what type of radiation are they talking about for you?
I got that somewhere in this amount of paperwork, but it's a combination, of course, with the hormone therapy.
Mm-hmm.
So that helps determine what type it is. I'm shuffling paper, so I'll find it if I'm lucky. Can anybody mention a type that might be appropriate, more popular, or whatever?
Well, I mean, it could have been SBRT, it could have been IMRT, it could have been brachytherapy. It could have been a bunch of different things. You know, I think that what we know now and we didn't know last week, which is really important, is that you are now a 4+3, and you were a 3+4. That we don't believe. Have you had a PSMA? Yes, you had a PSMA scan. What were the results of that PSMA scan?
I just got that back today, and of course, there's a lot of medical verbiage on it, and I'm not so sure. I'm holding it in my hand right now. So, what can I expect to? You want the findings?
Well, what we want to know is, did they see any metastasis outside of the gland?
I haven't had the consult on it yet to hear that from a doctor, but one of his aides emailed me today and told me it was good news that I don't see anything on this report that suggests there's any outside the gland.
Okay, so
good.
If that's the case, you might want to start going. We might be able to drop you down a group, which would be a good thing, so you don't have to listen to all this stuff about people doing chemo and everything else, because you're now 4+3, following cryoablation. We know that, and you don't seem to have anything outside the gland, so we may be able to work with you. I don't know. I'll have to defer to the maven on this issue, who happens to be with us tonight, Dr. Mark. Do you think this gentleman should be in our group or your group?
Well, I'm not possessive here, but we'd be glad to see him in our group. It makes sense because people are about the same situation. And I think you'll find you'll find it a bit easier to be in that group, and the discussions will be more relevant to your decision-making process. So we meet Monday, 5 p.m. Pacific time on the second and fourth Monday, same place. And we'd be glad to see you there, and we can go into a little more depth and detail into your story.
I thought because of the reoccurrence, they put me in a higher risk
Well,
area.
you see, this is where it gets tricky. It depends on your recurrence. So you had focal to begin with. If it had recurred and it had gotten outside of the gland, you definitely should be here. But you're one of these guys, unlike Julian. I think Julian left. No, Julian's still there. Oh, my boy, my man Julian's still there. Julian, it recurred, but it had gotten further and it was in his lymph nodes, right? Isn't that right, Mr. Morales, when it came back for you?
No, it never came back to me.
Oh, when your disease recurred, how bad was it?
It went to a 4+5 with Epstein graded it from a 4+4 to a 4+5, but
Okay,
unfortunately, it was all in the gland.
but it was in the gland. But
Yes.
Julian came here because he was clearly high risk. And so we knew we were going to have to talk to him about long-term hormone therapy. In your case, you may not have to do very long-term hormone therapy. So where you are right now is you're what's called an unfavorable intermediate.
Sort of like me in my situation. Mine was even more advanced than that. So I think the low intermediate group would be very appropriate.
Okay.
It
So for
is
Gleason
recurrent.
score,
Sorry, ask that again.
Julian's Gleason score was higher, and I
That's right.
guess that made the difference.
That's right. And in Dr. Mark's case, when he realized that he needed more treatment, he had seminal vesicle invasion. And so those push him into this group, and we navigate them in this group. But you, even though it's recurrent, it's still well contained. And anyway, Dr. Mark's much nicer than I am. You're muted, and it's just as well you're muted.
Yeah, I was going to say, lucky he's muted.
Yeah.
You're still muted. You got to unmute if you want to. You got to unmute. You got to unmute.
I
But
didn't
there
want
you
to
go.
stay unmuted. Okay. What I said was yesterday, everybody got 3 for the price of 1.
Yes. Yes.
Okay.
I mean, I often attend that group too, Bob. But I'm frequently in that. I'm frequently in a lot of the groups just to make sure the moderators are behaving. But you know, and oh yeah, and Dr. John was in that group yesterday as well. So we're not abandoning you, but I just think it's exactly what Dr. Marks just said, which is that it's probably a much easier and a better experience for you to be in that group than it is to be in this group. Jim Marshall has his hand up, and it's good because I wanted his opinion.
Well, actually, it's an opinion. It is a little more information about Bob. Okay, I've been speaking to him, and the catch is the doctors are pressing him to go on to then our ADT. Okay, fine. But
Right.
the catch is he is about to take a trip to Italy, okay, on a month or so, or in a few weeks. And so my thought or an idea I thought, well, do you really want to start essentially ADT and then take a trip overseas? And an idea that I had heard essentially others is maybe what he could do is to start the about a 2 month regimen for the Casedex and then come back to do the ADT. I don't know. Is that, a viable
I
option?
mean, he could definitely discuss that. I mean, the ADT that you're going to do, Bob, I suspect they're going to want you on ADT for about 6 months with the radiation. That's probably 6 to 8 months, and they tend to use 6 months nowadays. I would I would agree with Jim that if you're going on a month's holiday to Italy, it's not great. I think you have to go back to your people at Innovashare and say, do you think I can defer for a month? If I cannot defer for a month, how about bicalutamide Casodex? But the bicalutamide Casodex for a month is going to have an impact because the testosterone is going to be in your body, but it's not going to be absorbed by the androgen receptors because that's what the Casodex does. I mean, it's not like, well, I'll just take Casodex because I won't feel the same things like taking Lupron. You may feel it less, but it ain't a free pass. Dr. Mark?
Well, I didn't catch how many cores were positive at 4.3.
Uh,
5.
I'm
yeah,
sorry?
5. Yeah, 5 of, yeah.
And were they large percentages of 4 or small areas?
One was 60, one was 40, 2 were 10, and 1 was 5.
So that's certainly more than you'd like to see. My guess is that they're going to tell you enjoy Italy and then come back and let's do the right treatment. Some people used to say to do the ADT first and then start your radiation, but I think that's probably wrong in 2 counts. It probably doesn't make a difference to start it earlier and you'd feel miserable. But I'm thinking that 1 month is probably not going to make a big difference. And I think that's what you'll hear when you check in with your doc.
Yeah, and that'd be next Tuesday that I do that. I've got a
Okay.
session with them.
Yeah, and Mark makes a really good point, which is that, again, there was discussion. Mac even talked about it, and he had me on neoadjuvant. So I started before my radiation 6 or 8 weeks, but now he says a lot of times he doesn't even give neoadjuvant, especially if it's a 4+3 or a 3+4. He may start you at the same time or sometimes afterwards. So
The other thing that you might kill some time with, I think you need in all likelihood, you'll come to to getting ADT, but you might ask the doc also about the Artera test because that's set up now to actually give you predictive value as to the benefit you might perceive with taking the ADT. So how much does that decrease the likelihood of recurrence? And my guess is that might take 2 to 3, maybe even 4 weeks to get the results back, in which case you'd be back from Italy. So that might be one thing to ask if it's worthwhile to spend the time and do that to quantitate the benefit that you're going to see from ADT.
What test is that?
It's in the chat window, Artera, Artera, and they have 2 tests. It's artificial intelligence. One describes the benefit from taking ADT, and the other is the safety of active surveillance. You obviously don't need that because that's not where you are now.
it's not something we talk about much here because obviously it's not relevant to you guys, but it is FDA approved. However, for whatever reasons which we don't understand, it's not available in New York, state of New York, or the state of California.
Wow. And that's a blood test, Artera?
No, it'll be your slides. The computer will read it and analyze pixel by pixel to determine against a database of roughly 5,000 patients what your options would be, your best options.
Your biopsy slides, Bob.
Yeah, I see.
But it also takes into account things like PSA, age. There may be other factors.
So that you said it's about 3 weeks before the turnaround result is back.
It may be less. All I'm telling you is that if you're going on a vacation, potentially you would feel better if you're doing this test while you're away. It's not like you're doing nothing.
Yeah.
It should be covered by Medicare.
Okay. So they have what they need because they did an MRI or the biopsy, I mean. And so I just request I can put in a request from that over the phone.
Or when you're there with the doc, you ask them, "What do you think about this? Can we set this up?" And
Yeah.
their office should be able to take care of it.
Sure. Okay. All right. Well, if I'm getting kicked out of this group, I just want to tell everybody thank you. It's been good being here. I have enjoyed it. I appreciated Jim steering me in this direction. So I have enjoyed it, and I'm sure I'm going to enjoy the next one too, Dr. Mark.
He's in the
Well, yeah,
veteran group, so he isn't leaving some of us.
right. He's not leaving some of us. And I got to tell you, Bob, there's an added benefit. There's an added benefit when you go to Dr. Mark, because you also get to deal with our mascot, Andrew.
Oh, there's Andrew, right? Oh, good.
Well, in fact, Andrew is there in person. That's the Andrew on Dr. Mark's desk. But yesterday we had an uproar because everybody wanted to see Andrew in person, which they got to do. And the group lasted about another 10 minutes because they all wanted information and they wanted to. Andrew and I was there, and Alexa was there, and Andrew was getting spoiled rotten. Andrew is a therapy dog who works, amongst other places, at the Burbank Airport and at the motion picture home for the aged, and the Jewish home for the elderly in Los Angeles. And he was at our table. Andrew was at our table at PCRI. So that's the definite big benefit of being with Dr. Mark. So
So there's a breathing puppy, and there's the stuffed one, huh?
Yes, there's a real, yeah. There's
this
the real
one
thing.
Behaves and listens better.
Oh, all right. Dr. Mark, can you take some information and see to it that I get a link, or Jim?
I
have it right.
Same link that you're on here.
It's the same link, and I think you're already signed up. I think we signed you up to both, but I'll make sure. I'll do it right now, Bob.
Oh, okay. Good.
Okay, because I've got your details, but I think you're already getting it. And the next meeting for Dr. Mark will be on the 23rd.
Okay.
45 minutes to presidential debate.
Okay, thank you, Mr.
Yeah.
Fish.
Yes.
Thank you.
So I think if you're a cat person, you're out of luck. You need to find another group.
That's right. But don't tell Alexa that, though. Alexa would Alexa our Alexa. When I say Alexa, by the way, it's not the AI Google Alexa. It's our own Alexa, Alexa Jet.
That was the only problem about having them stay with us, that I had to whisper when I said her name because the lights would turn on or the windows would open and shut.
Look, I see Jeremy just came back on because he had to take his kid to baseball. Jeremy, you had something you wanted to talk about. Can we help you out before we all disappear? And you're muted. You're muted right now.
Yeah, no, I think you got a little brief. I saw my Euro-Onc today, and he actually referred me. Well, one thing I wanted to clear up, he wanted to clear up the pathology, and I didn't know if you saw that, Rick, but he took 4 turns at the bladder neck, and they were all positive. except for the fourth one, the last one. He kept resecting. So he just wanted me to understand that he did achieve negative margins. Um, and
Okay.
why they didn't give the pathology report when I asked for it, when you first told me about it, he didn't have an answer for me. But regardless, he recommended, as I said, he recommended to meet with this Linda or Lisa Chan um, over UCI because they don't have the machine that the accelerator. Um, Apparently, they have the accelerator on order, but sitting in a port, waiting to be delivered. But
Mm.
he didn't really say anything about Percy Lee, which was kind of odd. I don't know if he knows him. He did mention that Chan did her residency and fellowship under um, uh, 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 Dr. Roach at UCSF. And
Mhm.
she did her medical school at Harvard and then did her residency under Roach. And he thought that I would get along with her. So that's kind of where we're at.
So my best my best advice is to drop a line to TallAllen. Seriously, because he knows them all. I
Oh,
don't know Dr. Chan,
okay.
and he really likes Percy Lee. We had other people who say they like Percy Lee, and
Well,
you
look,
know,
it's City of Hope. They've got the latest and greatest versus Saddlebach Memorial Cancer. It's much smaller. Um, it's all about the doctor and the technicians, right? And City of Hope's going to have probably a higher uh, uh, amount of patients that they've treated, I would think.
hmm hmm
And so, my druthers is my predisposition is, City of Hope is a place to go. Um, so, but I will drop a line to Tall Allen.
Well, if
Let's,
anybody's going to be able to give you feedback, and
yeah,
she's in the area, I think it's
yeah,
going to be Alan who will be able to give you.
I
What do
will.
you think? What do you think, Mark, Dr. Mark? Because also
Well,
you
I
know
just,
this.
yeah, I think obviously Alan knows the various people. I'm not sure how familiar he is with what machines are available. Were you saying that they were supposed to have an MRI LINAC at UCI, but they don't
Yeah,
have it yet?
no, it's
And then,
sitting on a dock somewhere, apparently.
okay, so I know Hogue does, but
Yes,
if the machine is sitting on the dock, it's going to take quite some time
yeah,
between getting it there and getting it,
yeah,
online. And
right.
again,
And is it true the company's gone bankrupt? Do you know anything
it,
about that?
yeah, I know a lot about it.
Okay.
I lost considerable money on my investment. They
Oh,
were with Silicon Valley Bank, is where they got their credit
uh,
line. They lost their credit line. They had a hard time with deliveries because of chip shortages and COVID, and they just couldn't stay on top. So they couldn't get anybody to buy it. So the team that started it and was behind all the technology, was able to get new financing and got up and running again. Um, you hear a lot about the bankruptcy, but the machines are there. The problem is that one, there was a helium shortage for a period of time that interfered both with the Starliner and with MRI. And then they also uh, had issues of having to sign new contracts with the hospitals, and that took some time. So there were centers that were down. Most of them should all be back up and running. There's service available, so I don't think that's a problem. The situation, and knowing some of the people and the relationship that ViewRay had with the people at Hogue, they didn't seem to be interested in participating in the research or teaching programs and outreach. So I don't know what their status is. on using that equipment for prostate.
Yeah. Oh, the one last thing is, Dr. Uchio at UCI recommended, given my pathology, given the low PSA and my genomics, to try, he wants to enter me into a clinical trial with the use of this new tracer called Curium, which he believes has got a shot at detecting where the disease is at, the
That's
microscopic disease.
does it restrict what he does as far as treatment?
No, it does not at all. It does contain copper. It's copper based apparently,
Mm-hmm.
and
Oh,
I guess
yeah. He's a Brit
it's relatively new, but apparently, it's very promising thus far, and they can get me in 2 weeks.
That seems like a great opportunity.
But
So what
so
machine were they ultimately talking about with this doctor that they are referring you to?
it's just the same machine that that I
V-Ray.
think it's is that the ViewRay that City of Hope and UCLA have. He
Okay.
mentioned something about just the precision of the machine is supposed to be very, very good. But again, you got to target the disease. He said, look, the best thing is if we can target the disease instead of flying a little blind, that's where you want to go. And he thinks it's worth, I know it's another dose of radiation, but he said, look, it doesn't give you any more, expose you to any more radiation than a normal PET scan. It's the
Well, it's
tracer
actually going
material.
to be less than a regular CT.
Oh, is it really? Oh, interesting.
Yeah. So I
Okay.
wouldn't, I wouldn't, I
That shouldn't
wouldn't be
bother me.
alarmed about
Okay.
doing that. And
Okay.
in terms of the precision, that is most important when you get to the edge of the prostate or
Yeah.
you get to the urethra. You want to know on the fall off rate.
Right.
And the more beams you have, the easier they are able to shape it. So with proton, there's only 2 beams. There are 15 beams with the MRI. I'm not sure on Electas, but I'm sure that's a similar system. So it's more precision. They're only adding 2 millimeter boundaries versus 5 with some of the other true beam and other hardware.
And so I think that's what they have that's what's over at UCI is the CyberKnife, right?
Yeah, and that's a good one too. I mean, I think the CyberKnife, um, because the gantry is able to move and they also monitor the beam during the delivery of the energy, you have
Yeah.
some additional protection with CyberKnife over some of the others, which just take one CT shot before turning on the beam and don't monitor while it's live.
Okay,
But
guys,
yep.
I got to call it a day because we've
Okay.
only got 5 minutes until this room is again, and we've got to close the room and reopen it. And the MS people are starting to come in.
Okay.
Sorry.
No,
Sorry.
thank you. Thank you so
I'll
much.
talk to you.
Good night,
Pleasure.
everybody.
Okay.
Bye. Good night,
Cheers.
everybody.
Bye.
Bye-bye.
And I finally found my camera.
Good night.
Good night.
See.
Thank you very much.